Hi, everyone. I'm Stephanie. I'm here with Dr. Gowtham, and soon to be doctors Olawoyin and Lopez Carmen. Good, happy noon, everyone. If you all could just introduce yourselves, that would be great.
Should I start, Stephanie?
Sure, thank you. Yeah.
Hi, everyone. My name is Dr. Swathi Gowtham. I am a pediatric infectious disease physician by training and a pediatric HIV provider. And I've been dealing with COVID since the start of the pandemic. And so I'm very excited to be here. I'm honored to be here with all the other stellar speakers here. And hopefully, I can give you an idea as to an infectious disease doctor's perspective on COVID and the inequities that it has revealed.
Olamide?
Hi, my name is Olamide. I'm a fourth year medical student at Yale, and I recently matched into urology. I'm going to be staying here at Yale for that. And I was on my clerkship rotations during COVID. So I was actually in internal medicine when the whole thing started. So like hoping to offer some perspective, especially when things were just shutting down, as well as when we came back to the wards, when things had settled out a little bit more, and some of the long-lasting effects that I've now seen as a medical student. So I'm excited.
Thank you, and congrats on your match.
Thank you.
Victor?
Hi, everyone. My name is Victor. I'm actually a third year, and I go to Harvard Medical School. I am a member of the Crow Creek Sioux tribe. I'm also Yaqui, the two Native American tribes. And I am interested in Indigenous health. I've been working on, supporting Indigenous peoples during the pandemic in various ways, and looking forward to sharing some of those perspectives.
Yeah, it sounds like you're going to give a great perspective, Victor. And just for some background, I'm a fourth year med student at Temple. So I guess we can start with a few questions. In relation to the healthcare equity, what have we learned so far in the past 3 years dealing with the COVID-19 pandemic?
Again, I can start if people don't mind, and then please feel free to add in. So I just want to start off with some statistics. And so if you look at hospitalization rates and deaths, African Americans are 2.4 times more likely to be hospitalized due to COVID than their white non-Hispanic counterparts. And then Hispanic patients are 2.3 times at risk for being hospitalized with COVID. And 1.8 times more likely to die compared to their white Hispanic counterparts. If you look at it by age, I just have numbers. If you're a 35-year-old Black man, you're at 10 times more risk of dying of COVID than your 35-year-old white counterpart. So this was data that came out of Brookings Institute, where they looked at by population, how many Black people there are at that age, and how many deaths we've already had. And these deaths are earlier on in the pandemic, from like March to June of 2020. If you're Hispanic, you're at 8 times more likely risk of dying if you're a 35-year-old male compared to your white counterpart. And so particularly if you're a minority population, a person of color, not only were you at high risk of getting COVID, you're more high risk of dying and dying younger of COVID. So those were very early on statistics that you guys probably were seeing on the wards, that we've been seeing on the wards as well. But these were very startling statistics. I'm a pediatrician, so from a pediatric perspective, if you were African American, then you were at higher risk of being admitted into the ICU. And in pediatrics, there are two parts. There's MISC, which is the multi-system inflammatory syndrome in children that was very described. That's thought to be a post-infectious process. Your immune system goes crazy and starts attacking your body, including your heart. thinking that it's a virus. There's an HLA component to it. There's a genetic component and a predilection by race, similar to Kawasaki disease, but it's not all of that. These kids also were presenting much, much sicker. And so remember, equity in healthcare is not just access to good care, but it's also access to the right information. So anecdotally, I would see these parents and they're like, we had no idea she was this sick, you know, and they would come in really late and they would end up in the ICU. And looking at deaths in children, again, pediatrician talking, you know, if you look at 0 to 4 years deaths in the non-white Hispanic population so far, 0 to 4 years. So these are younger than 4-year children we're talking about. There have been 137 deaths in white children so far due to COVID itself. In Hispanics, that is 105. So Hispanic children make about 25% of the population. It's more than half. So they're disproportionately represented in terms of death. And this is just 0 to 4. Non-Hispanic Black, 91 deaths due to COVID so far in 0 to 4 years of age. These are children in first world countries, generally don't tend to die of respiratory illnesses. And as a pediatrician, you know, COVID really gets dismissed as children, oh, they're healthy when they get COVID. Most are, but a lot are not. And some of them are, some of them have died. There have been more than 1,000 deaths in children due to COVID itself. But this has been disproportionately affecting children of color. And then, so now we're going to talk about resources that are allocated to prevent and protect oneself from COVID. So talking about vaccination. So vaccination, when it first started, there was significant inequity. So these were limited resources. So when resources are limited, including tests, masks, you know, vaccines, and now drugs, antivirals, you know, how are they being rationed and allocated, you know, and is there an equity in that? And definitely we know, definitely in the beginning, you know, Pennsylvania was, if you're, I'm from Pennsylvania, so you were 4.7 times more likely if you were white in Pennsylvania to get the vaccine as if you were Black, you know. And I remember reading a Philadelphia Inquirer article about how in Philly, very early on, when there were vaccines that were being distributed to the community, 70% of their, about 70-ish%, don't quote me on the exact number, were given to white people. I'm like, how, you know, disproportionately so. So people from suburbia were driving out to Philly and getting vaccinations. And again, it's access to information too, access, you know. And when you asked African Americans who wanted to get the vaccine, a lot were hesitant, but disproportionately should. So they didn't know where to get it, you know, and where, you know, if it was safe, there was a concern, but they weren't sure if it was safe or not. If they wanted to get it, they weren't sure how to even get it. And then right now, in terms of who's vaccinated, fully vaccinated in the US, 41% of Blacks are fully vaccinated in the US. 59% of Indigenous Americans are fully vaccinated in the US. Hispanics have also caught on. It's 52% compared to whites, they're 48%. So Blacks are still lagging behind. Initially, you know, when the vaccines were first started, you know, Hispanic and Black vaccination rates were very similar. And then as more information started spreading using Spanish language communication, et cetera, the Hispanics have caught up and surpassed their white counterparts, but African-American rates have just flatlined still. So as we think about these statistics, you know, the way I like to think about equity is that everyone has the same opportunity to stay as healthy as possible. As infectious disease doctors, you know, something that inspired me to go, I have 1,000 reasons that I went into ID, but one of the things that inspired me was this equity part as well, where as pediatricians, natural advocates for our patients, we teach parents, we empower parents, we empower our teenagers to become good consumers of health, yeah, as I take care of pediatric HIV patients. And it's not surprising to us that infections themselves have opened up these cracks, these societal cracks. I feel like it's like water, you know, whether it's TB, whether it's cholera, whether it's diarrhea, you know, like the infectious diseases, impact the most vulnerable. And they split us apart, they fill in the societal cracks where they exist. And COVID to me was like a flood, more so than anything else. It just blew everything apart and made it more obvious. So when you think about, again, long-standing state economic, social inequities that have been leading to discrimination, that can cause inequities and rationing, limited resources, you have to be thinking about that. So now there are antivirals such as Paxlovid. I'm not sure if you guys have heard of that drug. It works really well if you test positive for COVID. You can take it. You have to take it within a few days. The earlier you take it, the better off you are. It reduces hospitalizations by 90%. Okay, so like if people are home testing and not asking their physician for it, they're going to end up in the hospital if they don't know that this exists. Again, access not only to healthcare due to lack of insurance or transportation and other means, but access to the right information. And then we also know that distrust exists in the communities, particularly the African-American community, given the history of Tuskegee, Marianne Sims, Henrietta Lacks. I mean, we can go on. And so there's a significant distrust, and how do we, get that message in to kind of try to gain the losing ground. And for me, it's incredibly difficult to see that, they're hard questions that we haven't answered. I have some disagreements with the CDC. Everything's being rolled back right now as if this virus doesn't exist. And I'm just like bracing myself, for something in the future that's going to come. And we have been woefully underprepared and continue to do so. The messaging has been inconsistent from the medical community, CDC being one of them, but all of us in general. And we've been woefully inadequate in presenting scientific data to our communities in an understanding, respectful, non-condescending manner, non-judgmental manner. And so there's a lot of work that needs to be done to protect ourselves from the next variant / the next airborne virus that's going to come. That's all I had. Thank you.
Yeah, and I know in Philly specifically, I think we are getting towards another peak. I saw in the morning news today that we're going back to potentially level 2, which means masking again.
Yeah.
And these things definitely impact children, even though we say that children can be healthy, even the death of a single child is a tragedy. Thank you, Dr. Gowtham.
Thank you.
Olamide or Victor, what are your thoughts?
I can go. That was such a great summary, so thank you for that. I feel like from my perspective, working with Indigenous peoples, not only in the U.S. but also globally, one of the things that we've seen is a disparity in like was said, a disparity in access to information, but especially in Indigenous languages. A lot of Indigenous peoples, not only in the U.S. but globally, more so elders in the U.S. speak only Indigenous languages. Only. They don't speak a major world language, and a lot of these languages are not written down. A lot of these Indigenous communities have no physicians from their communities. So how does the information go to these Indigenous peoples in an accurate way? And that was one of the huge challenges Indigenous communities were facing, and it created there's already so much mistrust, and it created an even greater barrier between the fear of this virus and getting the information that they need in their Indigenous languages, some of which are only spoken by up to 1,000 people or less sometimes, and Indigenous languages are the majority by far of world languages. I think it's like over 80% of the languages on Earth are Indigenous languages. Indigenous peoples are 5% of the global population. So I feel like there was an invisibility factor there when it comes to Indigenous peoples, and that extends to the United States as well. Indigenous peoples, I found, like, I was working on Boston's COVID-19 Health Inequities Task Force. And, we've seen it throughout the pandemic where Native Americans are left out of studies. Native Americans are left out of media on COVID-19. We're left out of data. I went to a center to get tested, and Native American wasn't on the racial category. I had to put other. And so there's this huge subset of data missing for Native Americans in this country. And many people don't know that Native Americans, this is from the CDC as of like March 22nd. Throughout the whole pandemic, we've had the highest hospitalization rates, the most deaths, and the most likelihood of getting COVID compared to white people. And many people don't know that. And it's because we're still suffering from this system that, that is not serving our people to the level that we need, especially on reservations, but also in urban areas too. So some of the things that, the powerful stories that I've seen in Indigenous communities is, and I guess a success is that our ability, the way that we operate as communities is we have our own tribal governments. We have our own elected officials on the reservations in the communities. And because of this, we were able to like control our own public health responses in many ways and not rely on the government, for instance, or not rely on a city government, but rely on our elected tribal officials in our community. And I think that allowed us to really hit the messaging in the ways that we needed to hit them, to really appeal to what we as Indigenous peoples care about, such as protecting our languages, protecting our cultures, protecting our elders. Many, for instance, for my community, we have maybe around 1,000 speakers left of our Indigenous language, and mainly elders speak it. And so as we saw elders, were getting hit and were dying. Every time an elder died, it was terrifying because much of the knowledge that they hold is not written down. It's not written down, and you have to go to the elder and talk to them face to face to get the stories that have been passed down thousands of years. And every time an elder died, it was like a whole dictionary of information was gone. And we had to really hit the public health messaging and do that on our own because the system wasn't really understanding us in that way. And because we were able to do that so successfully, we've had the highest vaccination rates of any race as well. So that was a huge success. And it is kind of like a little bit ironic, but, also a little bit, not intuitive to think that Native Americans have the highest vaccination rates because of the history we've had with the medical system and the mistrust, but the ability of our tribal leaders to help build that trust in our communities and say, the medical system hasn't won our trust, but, this is something we need to do. And this is sort of like a case by case thing. And in this time, we need to protect our people. And so that was, something that gave me hope, on a systemic level.
Thank you for that. I actually have a follow-up question. Given that it is probably difficult for you to even answer this question because I know that there's very little data on Native Americans and Indigenous people, would you say that given the higher vaccination rates, the levels of COVID positivity and death have decreased, or are people still being impacted disproportionately?
Unfortunately, we have the highest vaccination rates for dose 1 and 2, but we're lagging behind other races right now for booster. So that is something as Indigenous communities, we need to ramp up again because there was a lot of when it came to media, there was a lot of attention on Native Americans did so well with the vaccines. And now I think we need to come back again and continue to really hit it hard still. Because some of our communities have backed off because in so many communities, everyone is vaccinated. In my community, the majority of people are vaccinated. And there might not be the same intensity of public health messaging going out. You need to go back and get your booster. And so we are getting hit again, with the second wave, was mentioned. And we see the rates going back up again with these new variants and stuff. So, it's not over. We got to keep hitting the messaging hard like we've been doing.
Thank you. Olamide?
Yeah, thank you both so much for offering those insights. I learned so much. I guess I would probably speak on some of the disparities of seeing in the aspect of like the negative aspect of COVID that's not with people that were COVID positive, and some of the things that I saw on the wards that I feel like would have long lasting effects in our communities and in the lives of the people that those things affected. So just like a few like anecdotal instances, I remember back in March of 2020, right when things were still in the gray area where we weren't sure if it was in the United States or not, we had a patient who came in and I'd been to her primary care physician. Her blood glucose was like through the roof, but I think because of the anxiety surrounding the virus, a lot of people, their first instinct was this was COVID. And because of that, we kind of, even when she was in the hospital, just because she had like a cough or something, we completely lost sight of everything else. And we're so focused on what this could be. Is this COVID? Is this COVID? And I remember in the same time, there was a lot of infectious disease on the ward that required isolation. But if so many people needed to be isolated, then there's not enough space. And then there's just a lot of time that was wasted until unfortunately this lady passed away and it was not COVID. And for me, it was just like, we are so boggled down in this that we are losing sight of everything else. And I think similarly, there are several people who, I was on the medical student task force for my school when we eventually got pulled from the wards. And we had to call a lot of people who had appointments coming up. Some of them were cancer patients. And now when we went back to the ward in July, we saw that a lot of people were lost to follow up, which then meant that they couldn't get treated for their diseases and ended up dying from situations where they didn't have to die from. And I felt like, just from my experience, I don't have the statistics, but most of those people were people coming from minority groups. And the other thing I wanted to mention was also the importance of checking our privileges, even as medical students and people in healthcare. When the vaccination started, like the first dose started in, I think it was November of 2020, it was very striking to me that how easily accessible it was to medical students, even those of us that were not at the forefront. And for me, it begged a lot of question of what about the person at the grocery store who doesn't have access to it, but they have to go to work. I mean, I'm a medical student, I know that, but I don't have to be in the hospital right now. A lot of the first year students didn't have to be in the hospital, but for some reason, we were a part of the first set of people to get it. And that was very, very unsettling for me, even though I was benefiting from that privilege. And I think it's just something we also have to remember at all times. The other thing I wanted to mention was the effect it had, because I think now we're starting to get to the point where we're comfortable with it. And I hear a lot of people say, I'll just get it and I'll get it over with. But then we're forgetting about the impact it's had on, say, for example, education in the minority groups. A lot of students were out of school for so long. Groups that didn't have internet services, they definitely were super affected by that. They have a lag in their education that will probably last for the rest of their lives. Persons in Native American communities where they're very limited internet access definitely were affected. People in New Haven, students who come from areas where internet access is not as easily accessible or fast, were definitely affected. And I only wonder what that would look like 10 years from now in terms of what their education is like. And I think probably the final thing I would mention would be the impact it's also had on mental health, and somewhat brought forward to how important immigration policies are. So on the mental health piece, when I went back to the wards, I was in pediatrics in July, and kids had been in isolation for so long. And we saw so much rise in children who were suicidal. So we had 10-year-old kids that were on the ward for suicidal ideation. We had kids who the only way to control access in their lives was through their diet, and they were having bulimia, anorexia, different things like that. And of course, this is not something that's going to end with COVID. This is something that's going to progress forever. And then lastly, we had another kid whose family is documented. And he had MIS-C, which also had kidney failure, needed dialysis. And that for me was just a highlight of how important access to health is for the immigration community, especially those that are undocumented. Unfortunately, in Connecticut, if you're not documented, you don't have health insurance. And that begs the question of what happens to a kid who needs dialysis for the rest of his life who is undocumented. And we started playing this game of the hospital isn't willing to pay for it forever. So what do? Do we report them to immigration because the kid's in dialysis? And this was a way where a lot of people came to advocate for this kid. And the only option was for their family to somehow get legal residency in New York, because New York does offer health insurance to people that are undocumented. And that asks a question of why can't every state do this? And what do we do for these kids who are so vulnerable? And now that we're now in the situation where we're so comfortable with COVID, but what happens to all of these families whose lives has been heavily impacted, and where do we go from now? So just to say, like, asking everyone who's listening to not be so cavalier about it and continue to think of our the consequences of our actions and how it affects other people as we move forward.
Thank you for that. Yeah, I think we talk a lot about how it impacts people who are COVID positive, but we don't often think about how it impacts the patients who aren't, or even the family members of those people. Your first example actually reminded me of a case that's close to home for me. This is actually almost 2 years to the anniversary of my uncle's passing. He didn't have COVID at all, but we didn't know that he was sick or anything because he didn't have a mobile phone that gave him access to video calls like an iPhone or anything. And for that reason, we couldn't see him and he couldn't speak to us because he did have a different respiratory infection that just wasn't COVID. And so it impacted my family really heavily because he died so suddenly to us, even though he'd been sick for weeks. And I think that that's something that has impacted so many families, not just my own, but all across the country and across the world, who haven't been able to see their family members because of visitation policies and fears that they would catch COVID if they were to go visit their family members. And that's just something that I've thought of just because of what you said, Olamide. So thank you.
Yeah, sorry about that. Thanks for sharing.
Another question for you all. What are some policies that need to change to ensure better outcomes for underserved communities during future pandemics?
I can start. You guys want. So, I think I don't think you're going to get anywhere. What this pandemic has taught me in this era of social media and ready access to misinformation is that you're not going to get anywhere unless you get buy-in. And as Victor had clearly outlined, you need representation from the community. You need respected leaders, representatives that the medical system should communicate with. And I think the messaging has to be easy. It has to be consistent. CDC has made many mistakes. One of the major mistakes I feel was in April of 2021, when they said that vaccinated people can stop wearing masks. It was amongst the infectious diseases, forums, it was incredibly controversial. Many of us did not agree because, after vaccination, even though it was 95% efficacious at that wild type variant at the time, people, they just measured who got sick, as their endpoint. Nobody went in to do swabs like every week in that group. So you didn't truly know how many of the vaccinated people actually had asymptomatic disease. And that was one of our messages to my frontline staff. I'm like, you have to get vaccinated, but you still need to wear a mask with a patient, because that was a misconception even amongst healthcare staff. So the reason why I said was that, because nobody went in and swab these people, so you could still pass it on. You may not get sick and you may not get as sick, but you could still pass it on to other people. So please wear masks. So when we said that, and then the CDC removed it, I'm like, great, what do I say now? And then all the mask mandates went away. The governor said, yeah, we can't make people wear masks. How are we going to know who's vaccinated and who's not? And I was like, have you met as American CDC? Like, how are you going to know this, in the public? And so unless you had a mask mandate, that everyone's masking regardless of vaccination status. So when the mask mandates went away because of the CDC guidance, they were never going to come back. It was going to be fighting an uphill battle, to get those back. So I think that was one of many mistakes. Going back and forth and all of that is many mistakes. And I engage with patients. Again, it's who we are, what we do as ID, as pediatricians. We engage with patients. We talk to families. We tell them why we're doing a certain treatment. We try to explain it to them in lay terms. And so that's second nature to us as physicians and who are on the front line. I wish CDC was a little bit better. Other societies were a little bit better with that. I think that's what we need to focus on: communication, engaging communities directly. You need to invest in the local community needs. You need to go and figure out what the needs of those communities are. There are many lessons that have not been learned. There's politics seeping through the science, and that was not just with this previous administration, it's with this one as well. That is incredibly disappointing. So I'm just a little, nervous about what's going to happen, and I don't think we've learned all our lessons. So there's a lot of stuff that needs to happen. It's encouraging to see communities like these and leaders like you guys engage, but always be advocates for your patients, to that patient in front of you.
Thank you, Dr. Gowtham. Olamide, what do you think are some changes that you would want to see in policies?
Yeah, I feel like that, I hate to be pessimistic, but it's so deep-rooted in a lot of systemic issues that I feel like even the CDC's policies are so tied to capitalism as a whole, and it's all so financially dependent. Now I've been following the policies of people really pushing for the aviation industry to stop vaccination mandates as well as mask mandates. And I think it's very silly. But of course, when you think about it, if people don't have to be vaccinated and that's not a barrier, people don't have to wear a mask on the plane, then that obviously increases their ability to have more people on the plane, and then increases their ability to make more money. And it's just the cycle. So, and then obviously the police, how heavily COVID was politicized was such a huge problem. And I think that was part of the problem why it had such a long-lasting effect, and how such a powerful country like this country could not get it under control. I think also the cultural thought processes in this country is very deep-rooted in a lot of selfishness, for lack of a better word, in that we're very concerned about just whatever is affecting me and my family. And as long as it's not affecting us, I don't have to do this, I don't have to do that. But I think that probably one thing that we as people in healthcare continue to do is just seize every opportunity we can to encourage people to be vaccinated and getting the word out there very early on. I think as far back as February or even January of 2020 was when COVID started to become something in the hospital, but not a thing that people knew. So I felt like maybe at that point, if we were more aggressive with letting people know that, hey, this is a infectious disease that could very impact our society, maybe this is what we should start doing before it has an impact, then we could have probably gotten ahead of it more than we did. I think we were so quick to say, oh, this is a problem of China. This is a problem that's probably going to mostly affect developing countries, and it would never have anything to do with us. And I think because of that, we got so comfortable and we didn't know about it until it actually hit us. The other aspect is a lot of the education around COVID is so heavily tied to media. And the moment media moves on, then we all move in as well from it. So now we've been so distracted by say the Oscars or something else. So we've not hit anything about the rise in COVID cases, even though it's happening. So I think just a matter of seizing every opportunity we have to talk to our people about it and encourage people in our community and say, you have to get vaccinated. The other thing that we've been doing a lot heavily here at Yale is training medical students and people in healthcare in general, and even undergrad students, how to give the vaccination. So that way it's been accessible to as many people as want to take it. There's also been efforts to encourage persons who are in high school student, teaching them how to be advocate for COVID vaccination. And that way they can also go within their communities to tell people about the vaccination, and hopefully that would have an effect. So I think probably moving forward, if God forbid this happens again, it will be a matter of not being so, not thinking to ourselves that this is never going to happen in the US. It can happen here too, and we have to figure out a way to get ahead of it very early on. before it like festers and becomes a huge thing.
Mm-hmm. Absolutely. It's so easy to, and lovely to think it's not going to happen to me until it does. Victor?
Yeah, one tangible thing, like I think, is supporting native communities. I think to supporting, like, make sure they have enough funding for their healthcare system. Like, not many people know about the Indian Health Service and what it actually is. And it's a treaty responsibility because Native American tribes, when their land was taken, when they were forced out of land and onto reservations, which were originally prison camps, that they would patrol around the reservation. If we left, they would kill us or put us in prison. And part of the bad deal was that after they took our land and put us on reservations, they promised that they would provide us health care. They promised that in treaties that are written down, like nation to nation treaties, like a treaty between the US and Germany, or US and Australia. We have treaties between my nation and the United States still written down. And many of those treaties have been broken, but in those treaties are promises to healthcare. And that's where the Indian Health Service came out of, that Native Americans, through these treaties, the United States has the obligation to provide us sufficient healthcare. And Indian Health Service is currently, that's what serves our communities. It's a government-run agency that provides healthcare to Native American communities. And currently, it's just it's so underfunded. And like, compared to Medicaid and Medicare, I think we get Native Americans are funded per person half as much or less than Medicaid and Medicare patients per person. We're funded, I think, three times less than prison populations. And not to say that prison populations deserve less; they deserve more as well. But I'm just using that as a comparison to show how underfunded our healthcare truly is. And the obligation of the United States is to make sure we have adequate funding so that we can provide for our communities. And what part of the problems with the funding structure of the Indian Health Service is it's appropriated by each year, or could be every 2 years. It's debated on the floor of Congress by members of Congress who are elected. And so it fluctuates, unlike Medicaid or Medicare, which is funded based on per person. A certain amount of funding is agreed to per person. Indian Health Service is funded, 1 year it could be adequate, the next year it could be way less, depending on how the debates go on the floor and what the members of Congress agree and vote upon. And Native Americans have to go to the Hill, to Capitol Hill, and advocate and say, we need this much money, and we never know how much we're really going to get. And so there's no stability in the amount of funding that Native American health gets. There's really no stability. And that's so different from Medicaid and Medicare and every other government health program. We're the only government health program that is funded that way. And it really creates problems for us. And yeah, I think that's one of the most tangible things that can be done policy-wise, is to change those things.
Oh, I'm learning so much from you. I think that's absolutely horrible, though, that we're treating Native Americans so differently from everyone else.
Can I ask a quick question?
Yeah, absolutely.
As I was looking for data on other races, Asians get lumped together, as if we're the same thing, and same race. Do you think, obviously do you think just having on the ground data is going to be helpful, health inequity data for Native Americans? And then the other question that I have is, when Indian health services are run, is it a top-down approach, which a lot of people who, quote, do global health, unquote, sometimes tell a community what they need, then get the community's response and act accordingly? How does in your opinion, how does the Indian Health Service work in that way?
Gotcha. Yeah, data is everything. One of the most basic data points that we need is a better census for Native American people. For instance, like we have PO boxes. Most Native Americans reservations get their mail from PO boxes, but until recently, the census didn't send census information to PO boxes, only address, like regular addresses. So we're so undercounted that the ability for the government to say, like, this is how many Native Americans there are in this country and this is how much funding they need, like even that is not, where it needs to be. So, that even the most basic data points like that, we're really lacking, and you really need to bolster that. And then, the Indian Health Service is, it's run by the government, but tribes, if they have the capacity to, they would do what's called 638 and take over their own tribal healthcare systems, and do that through funding from the government. So the same amount of funding, except the government is really no longer running it, although they are auditing it and things like that. One of my tribes did that. We have our own healthcare system now, and we contract with another healthcare group with the money from the government, and we're no longer like tied to the IHS, no longer in that bureaucracy. But a lot of tribes don't have the capacity to do that because, lacking like healthcare workforce and administrative workforce to be able to run something like that. So it just depends on which tribe, and in global health, I feel like, we could actually benefit from being included in global health a lot more, because like a lot of people, when they consider global health, they think of countries so far away, when literally, like, legally we're considered, our own sovereign nations. We always have been. And that's how we operate. That's how we think of ourselves. And we have treaties, nation-to-nation treaties with the government. I mean, obviously, we are like our own little countries. We have our own languages, our own cultures. We have, like, one of my tribe has the second shortest life expectancy in the entire Western Hemisphere, behind Haiti.
Oh, wow.
And many people in global health, like, they're forgetting Native American nations. They're forgetting us. So I think we could benefit from, like, much more inclusion in that field.
Thank you.
Yeah, I think there's so many policy changes, you're right, that could be going towards helping Native Americans. Absolutely. My next question. The pandemic highlighted the importance of community leaders and local institutions in relation to continuity after the COVID-19 pandemic.
Again, I can start. Sorry, I'm hearing background. So maybe, I agree. Engaging community leaders, trusted representatives is very, very important. Having that connections that we've already developed, they need to be maintained, not just for COVID, but for other health disparities, diabetes, cancer, hypertension, et cetera. Mental health, all of those things for the well-being of the patient and the community itself. My concern is that pandemics, infectious diseases cannot be handled locally. We need, I think this is one of the, again, another big mistake. I mean, the CDC made recommendations, but there was really no way to enforce it. A state could make its law, like Pennsylvania could do a great job, but if New Jersey didn't, like, I can't stop it at the border, I can't stop COVID at the border. There's intermingling and all that. So we all have to do it, as a country, but then globally too. If Africa does not have enough vaccines, that will affect the United States. And if China, the Chinese vaccine, currently what's happening in Shanghai is brutal. I'm not sure if you guys have seen videos from it, but it's like every country has had, India, for example, what happened in April of 2021. So infectious diseases it's not a bubble, and there needs to be definitely local involvement, boots on the ground, doing implementation. But the policies, the resources, should be not only national, but also global. And WHO and CDC, will make recommendations, but we really need a governmental way of looking at things, and things may be implemented in different ways. Data can be shared, and depending on populations, but achieving the same end goal, I think is very, very important. But as important as local leaders are and local communities are, because they help us disseminate the correct information and get buy-in from the end user and the patient and the public. I really think it should still be, there should be some resource allocation and policy allocation that should be consistent, clear, coming up from the top as well. Sorry.
I completely agree with that. I think at the beginning of the pandemic, I remember something that shocked me was when the then President Trump said that he was not the US Postal Service and he wasn't a mail carrier and he wasn't going to be in charge of distribution of PPE, and he left it completely to the states to manage their PPE distribution. And that led to a lot of inequities. And even if things were equal, they were never going to be equitable. And there were so many states that were impacted more heavily than others. So even just on a national level, it wasn't fair. And then we have so many people coming from other countries that, regardless of how we manage our own nation, they impact us for sure as well. So thank you for that, Dr. Gowtham. Olamide, Victor?
I think one thing that probably comes to mind would be that COVID, just like the title, definitely exacerbated some of the things that has always been wrong with the healthcare system. So I think one of the ways in we can probably get like local people in the community, local leaders engaged would be just allowing ourselves to understand the needs of the community and how we can meet them at those needs, as opposed to this idea of like paternalism that we do a lot in medicine, where we feel like we know it all and we can just go into their communities and do whatever. But actually understanding some of that, psychosocial aspect of healthcare, I think is also very important. And we can only understand that by engaging people in our communities, going to their meetings and trying to see what their needs are. Because I feel like if that was done very early on, that could have decreased some of the hesitation that came with like vaccination and things like that. So just trying our best to undo the wrongs that is happening so long in our communities that we serve as medical people, I think is also very important.
Thank you. Victor?
I definitely agree. I think one of the the takeaways from all of this as well is that, like, for me, I think it really highlighted certain populations and vulnerable groups that are often like left out in policy. And I think, like Olamide was saying, one of the things that I see like is mental health and how does that play into it, and then people with disabilities as well. And I would just like us to take out from this, like, that we need to bring more attention to those groups, to people who, I think especially people with disabilities, and like how they like how can we partner with them, and also like people homeless, people who are experiencing homelessness too. How can we partner with them to create solutions and make this world a better place for people that like we've been forgetting.
Absolutely. I completely agree that we have been underserving the already underserved and the people who need the help the most. I have one more question. So if anyone who's watching has any questions, please put them in the chat so that we can ask our wonderful speakers. My last question is, a significant part of the hesitancy of getting vaccinations in the underserved communities is due to mistrust for physicians and other healthcare professionals. Why do you think that is? And how can we as medical students combat this?
So I think you can be powerful advocates and representatives to the community itself by showing that you're sincere in your efforts. patronizing, not, condescending messages. Oh, if you don't take this vaccine, you're going to kill your grandmother. Like that kind of stuff doesn't really work. So messaging, you always have to think about what your audience cares about, right? Like, so what motivates them, what scares them, particularly when it comes to the vaccine. So I can give you one quick example. One of my first patients that I took care of for MISC, this is kind of what highlighted how the medical, like the inequities and the racism, inherent racism in medicine. So the first kids that I've taken care of with MISC, he was coming from a local hospital, and the physician that was transferring, was calling me and was trying to get the history. And they're saying, I tried to offer this mother remdesivir, and she was not allowed to see her child because from that hospital policy, because he's 18. You know how we were not letting visitors in for COVID positive patients. So that was another huge thing that we have done wrong. Many things, I can list them out. But when I was talking to the provider, they said, this is a very difficult mother. She's not letting me, give the patient, and he was too sick to consent. She was not giving consent. It's a very difficult family, very difficult mother. And I'm like, okay, so I don't understand what you're talking about. So when the child was transferred to our ICU, I was able to call mom, and I explained everything as I would normally explain things to my own parent, explain the pluses and minuses, why I don't think this drug is experimental, how it would benefit, what the, pluses and minuses were, gave her respect, asked her time for questions, asked her what she was worried about, what she was scared about, and there was definitely a delay in treatment because of that, because of this lack of communication and assumptions that were made. And so that was very early on in the pandemic, and so this was, the patient ended up not needing remdesivir and needing another treatment. But regardless, I was able to convince her of what the treatment was going to do and help her child. So it was a very pleasant conversation. There were no issues because I did not assume anything, and I showed her the respect and answered her questions as I normally would. So, people get labeled as difficult patients, difficult families, and then I think that also diminishes care. And as a medical student, when you see that happening, so when I called the person back, like, hey, by the way, your patient did not need this, but needed this instead. And FYI, I had a very pleasant conversation with the mother when she understood everything. How did you, I didn't want to say it to them, but I was like, how did you actually explain it to her? That made it, it's like, oh, we don't know what it's going to do, and this is experimental because it was a new drug, how did you explain things? How did you bring that message? Any parent would say, oh my God, I don't want you to experiment on my child if you don't know what it's going to do, So you have to say what we know, what we would worry about, what we would monitor for. There's a way to present the same data. If this was my child, I would do the same thing. There's a way to present that to parents and families. So be an advocate for your patient, no matter what you do. You don't have to do anything big. If you want to do, great, aim for everything, but think about the patient in front of you if you're going to do that, and advocate for every single patient that you're going to see.
Thank you for sharing that experience. I'm glad that patient and their mother had you to be their advocate. I think that's definitely something that all of us can use moving forward, just coming at things with an open mind and being patient with people. Even when we're told they're difficult or we think they're being difficult, there's always some room for compassion.
Yeah, they're most likely scared.
Exactly, yeah. And it's definitely our job to break through that and work to be their advocates. Victor, Olamide?
Yeah, I think, one of the major things we need to do is we need to have more, bringing more physicians from those communities into the field, in real ways, and sort of acknowledging the medical field needs to acknowledge what it's done in very public ways. And sort of I feel like there is a case for reparations for what has been done. There needs to be healing in tangible ways, not just words. There needs to be healing for everything that's been done. I mean, one of the, the most well-known examples is Henrietta Lacks. Has the Black community been, had reparations for all the funding and the billions of dollars that came from that mistrust? Have they benefited from that? Has there been real restitution for all of these actions? And I don't think so. And then also, like, yeah, more Black doctors, more Native doctors, and that's going to take some radical transformation of, maybe the application system, the testing system, recognizing the systemic faults, like in education in those communities, and making things really more just. I think we really do need to hit like those injustices much harder than we are right now.
You're right.
Yeah.
I think even the people who are, oh, sorry, go ahead.
No, you're first.
I was just going to say, even the people who are watching this and us as well, I think even just existing in this space we're able to make room for change just by being people of color. So that's a really great point. We definitely could use more people like us, advocates, for our patients so that they can see and be able to trust us. I think I, as a medical student, and I'm sure you both have had this experience where comfortable compared to every other that's been providing their care, just because we might look like them, and we might look like their family member, and there's a level of trust just built in just because we look like them. So thank you. Olamide, before I cut you off.
Sorry. Yeah, I definitely agree with everything that's been said. I think also just realizing that a lot of the relationships that happen in the hospital begins right at the door. Like it begins the moment you meet the patient for their intake. And so just reminding ourselves that if you're going to be having a difficult conversation with the patient, it probably would go a lot easier if when you met them for the first time, you sat down to speak to them and you sat down to ask about their needs and desires and what they already knew about their medical care. I think that makes it a little easier for like conversations that now requires them to make a decision that they may not agree with to go a little smoother. I think the other thing that I personally am working on, and I encourage everyone to work on, is also not to be so polarizing in our thoughts. Not say, oh, they're anti-vaxxers, so like they're anti-vaxxers and they're just this, and like they're never going to listen to what I have to say. We don't know why they are. We don't know the reason behind that. So we also have to try to first understand why people are making the decisions they're making. And then I know we have very limited times, but then try to use that as an hint to have whatever conversations we want to have with them. And lastly, I feel like even in communities that not beyond implicit biases ourselves. Like I'm a Black person. I find it very easy to relate to things that people in the Black community are struggling with. I'm also an able-bodied person. I may not totally understand what people with disability are going through. And so I should always be willing to learn from and see how I can best meet the point of their needs in ways that I understand. So I think just some of the things that I have highlighted that I definitely could do more work in and continue to work on.
That's a really excellent point. I think whether our patients look like us or not, it's so helpful for us to meet them where they are and understand where they're coming from. And I think that it's so easy coming from our being what we think is medically educated to come with a polarizing view, but it's even more important to treat them as patients and as people and see how we can help them in their goals of care. So I completely agree with that, Olamide. Okay, so we have a couple questions in the chat. The first one's for Dr. Gowtham. What current initiatives, research, and projects are you working on currently?
So lots of things. I am the Pennsylvania chapter AAP, American Academy of Pediatrics vaccine champion. So I don't know who lives in Pennsylvania. Apparently there's an ad of me going on vaccinate your children ad. That's basically, a lot of it was lobbying, for in-person mass that was done for students in school. And so my current research initiatives are related to vaccine uptake in children. So I'm working with the PAAP on that. The other thing is that I'm an HIV provider, so rural HIV. So I trained in Baltimore at Hopkins, and then I moved to rural Pennsylvania, so red country. So very different culture shock. Rural needs for HIV patients are very, very different than urban needs. I think the discrepancies are higher in the African American community, even though 97% of the patients that we serve are white. African Americans make up around 26% of our HIV patients. So again, disproportionately represented. Do they have a car to travel several hours to see us? So I do a lot of outreach clinics. So there's a PrEP initiative that's going on, and we're applying. We have some funding, and we have more funding to kind of publish the needs of rural patients with HIV and the inequities that exist here, because a lot of the data that comes out of HIV is in urban centers. So those kinds of initiatives I'm doing. I'm also a member on the Geisenger has one of the strangely, like it's very well connected EHR system. We're I think we are the first in the country to have Epic. So there's mounds and mounds of EHR data. So there's a DEI committee, health analytics committee, and I represent the medical school and pediatrics, the Department of Pediatrics in that committee, to try and see how we can use our analytics resources, our hefty analytic resources, to ship through that data. So I learned a lot, Victor. So I'm going to try and see what we can do I was taking notes, for Indigenous people in Pennsylvania, at least, to try and see what we can do here. But to try and kind of take that data and how do we focus it to empower our patients. What I've learned as a physician who takes care of adolescent HIV is that I need to empower them. Like in Baltimore, we used to say, if they go to the adult world, they're going to die. So there's a way to transition adolescents so that they can be their own advocates when they access an increasingly complicated healthcare system. So how can, Geisenger, the EHR, the technology can make that thing easier? So one of the things is the CDC has social vulnerability index. I'm sure you guys are familiar with that. Kind of maps out like communities that have high minority population, that live below poverty, et cetera. Like there's multiple social indicators. Geisenger's developing, I'm sure other healthcare systems are, developing, using that index to kind of hone in on who those patients are. I'm kind of hoping this is just in its infancy, that we're going to have something to say, hey, you are Indian, or like we have a high risk of diabetes. I didn't realize that. My dad is a diabetic, and it's not related to obesity. And Victor, I learned this very recently. There was a news article in the Indian channels that said that colonialism, the fact that 200 years ago, my dad was born in independent India, nothing to do with the Brits, colonialism and the 31 famines that we had in the Indian subcontinent put subsequent generations at higher risk for diabetes, because we don't know how to, we store fat, and we don't know how to metabolize glucose, and that's who survived a perpetual starvation state. So those genes have been passed on, and years on end, that's doing that. So again, data is what's needed. So if you have, racial data, economic data, targeting and telling a patient, hey, you're at high risk for this. I see you have an appointment in 2 months. Don't forget to talk to your doctor about getting a hemoglobin A1C, and to the doctor saying, hey, you have X amount of patients that have a hemoglobin A1C of greater than 9%, and 50% of them are African American. You need to do better. This is how you compare to your other colleagues across the system. So that type of feedback, I want to use data to kind of give that type of feedback that would be more useful for both the front line from a provider end and from a patient end as well. So lots of things going on.
Yeah, we're so lucky to have you with all of your different perspectives and experiences. Thank you. My second question I see is for us three students. What do you hope to work on as incoming residents? Olamide, if you want to go first, since you're a fourth year.
Yeah, I think that for me personally, we've all mentioned today like the importance of representation in medicine. So for me, like I just have this huge dream of completely changing the face of medicine, which I think will heavily change the culture within medicine as well. I'm going into a surgical subspecialty, and I feel like there's often the language around medical students where we're just so afraid of it because it's almost like the culture has been malignant, has been so normalized. And I really, really hope that I can change a kind person to the medical students, to the staff, and wherever I come in contact with in general. I also think a lot too, for example, the hearing of of Judge Kataji Jackson, and how in all of the things that were going on, it just took one person like Cory Booker to say, you know what, you belong in this space and you can do that. And I really hope to be that person that's able to continue to encourage the next coming generation, and let them understand that they can also belong in the space, because if I'm able to be here, there's no reason why they also cannot be here. So I work a lot with like persons from inner city schools here in New Haven, and just continue to do some of those work. And also people coming from other countries in general, encouraging them that there is a space for them here in this country as well. So those are some of the things I really just want to continue to be a kind person. I think that is something that I'm really hoping I can continue to do even after the 24-hour shift and the tiredness and just days of being human. So yeah, I think that's the biggest thing I want to remember, is to just be kind.
Excellent, thank you. Victor, I know it's a little far away from you, at least a year or so, but what are your thoughts on your goals in becoming a resident?
Yeah, I really love the idea of like being kind. I think that's so important in medicine. So important, and trying to take care of yourself, like become a more just a kinder person. I feel like it can be difficult to integrate all those self-care practices and make sure that that you're still growing, and with all the obligations and the limited time you have. And I'm really excited to do that as well, and to really just like get to focus on medicine. I think I see my residency as a time like where I can just really focus on becoming a better doctor, so I can serve my communities in the best way. I think as a medical student, um, we're learning and stuff, but we do have this huge opportunity and sort of I would say somewhat leverage as students through our innocence to sort of still be advocates. And we're not technically employees at this point either, so I think there's a sort of power in that. uh, and I'm excited to see how I can still advocate as a resident, how I can still be involved, and maybe I might have to change my strategy a little bit, but to see how I can still be effective and be a good example for Native youth. I think I know that when Native youth see me in medicine, like they feel like they could do it too, especially the ones from my community. So I'm excited to finally have that doctor by my name, the MD, and to show them like, yeah, you can do this, and to just try to get as best as I can at medicine, so I can go back and actually be effective in my communities.
Yeah, I feel like there are never enough mentors for students who are underrepresented in medicine. I think if you're able to get just one person to see that they could become a doctor too, or become involved in higher education and help to better their community. I guess I'll answer. I didn't say this, but I'm going to Brigham and Women's. I'm going to be specializing in psychiatry. I think there are a few things I want to work on. I think for one, I want to be someone who other students and patients can identify with. I think one thing that was important for me when I got married was to not change my name to a white man's name. I married a white man so that people could see that I am African, I'm Nigerian, and be able to identify with me in that way. I think it was also important for me to come in with my naturally curly hair, because I think if my hair were straight, I would be a little bit more racially ambiguous. Just different things that I think can allow people to identify me with them. And I think in psychiatry, I'm really interested in women's mental health and the mental health of underrepresented people and underserved people. So this, and specifically the intersection of people of color who are women. I think that there are so many disparities that affect women, people of color, especially in psychiatry and mental health, that just aren't being addressed in the same ways. There are different traumas that women experience more heavily, and especially women of color experience more heavily than others. And also within perinatal and postpartum mental health, that's something that's also very important to me. I think as a person who's actually also pregnant, I think that's something that it has been at the forefront. Because people who, especially Black women, aren't just treated the same throughout care, but especially in pregnancy, the rates of mental health issues and even death are so much higher in than other groups. So I think for me to just be an advocate for those people and to be that person who's their care provider, to get the opportunity to do that would be really great for me. Okay, so another question from Simisola, also at the student panelists. I assume medical school has been way different than you imagined. How has witnessing patient care and experiencing your clinical years during COVID influenced your career path, especially in specialty interests, research interests, motivations, advocacy, etc.?
Yeah, I feel like probably the most shocking aspect of medical school for me has been how the most difficult aspect is not even learning. It's really the loneliness that sometimes occur where you just feel like you are the only person going through whatever it is that you're going through. And I think also it's, especially in the wards, it's like so fast paced that I think that some of the values we learn in medical school, like during the preclinical years with like clinical skills and things like that, are often just like entirely forgotten because there's just not enough time sometimes to get to the root of the problem. And I think that for me drew me to a specialty where allowing people to speak about some of the most intimate things that they would never be able to talk to anybody about, sometimes even with their spouse, was very profound for me. So I actually went back and forth a lot between urology and psychiatry because they carry similar values of how can I help a patient who cannot talk to anybody else about whatever it is that they're going on. They're especially people who outwardly seem very powerful, like men. I think oftentimes we like ignore completely like men's health. Because they're just not supposed to be vulnerable. That's what society has told them. They're not supposed to be vulnerable. They're not supposed to be emotional. And I think that really drew me to that specialty in the sense that in clinic, I can talk to them about things that they can't talk to anybody else about and how I can help them. And I'm very big on like preventative healthcare. And so I feel like that was a specialty for me where I could do a lot of preventative healthcare, but also do some more intervention. I think that's why I ended up choosing urology. In terms of like advocacy, I'm really huge on advocacy when it comes to how we can increase representation in healthcare. So coming from the next generation, so like high school students, and also working a lot with leaders in our community. So I do a lot of, like in my early years in medical school, did a lot of work with persons in the New Haven community where we would go speak to, we invited us into our medical school and just try to get a better understanding of how we as medical students and people in healthcare in general could help them and what we could do better. So that was very enlightening and also very enriching. A lot of the reasons why I decided to stay at Yale and open to continue to do some of this work.
Thank you. Victor?
Yeah, I for me, you know, coming from a background to medical school where I was always surrounded by Indigenous peoples. Like I always had that home base or that group, whether it's family or friends, you know, wherever I was prior to medical school, I had always had that home base of Native Americans or Indigenous peoples. And Harvard was the first place where I felt like I really didn't have that. And it was very lonely, you know, to come to a place where there's only maybe one other Native person or zero in like, you know, over like 1,000 students in the medical school. Like, you know, not a lot of people can imagine that. what it's like to go through that and to be like really the only one in all of your classes. It's not great. It was definitely hard, and it's still hard, but I think it really showed me like, that first of all, like what I'm doing, like being here, it's so important. I feel like I am in the right place where I'm needed. And then what I want to do after, like I realize that I want to be with my community. Like I want to sort of change this. I want to, help more natives get into medicine and to change the system for the better. But to also like to be honest, it made me sort of think about like what I want to do in my career, and thinking about like, what do you want to stay in academia, or do you want to go into your own practice or do something else? It kind of solidified for me that personally for me, I'm not that interested in having a career in academia itself, like being connected to a university and things like that. I'm more interested in being connected with my communities, being able to be home in my communities as a physician. To me, feels so powerful to be able to go to ceremonies, to not have the burden of academia, which I find is a huge burden for Indigenous peoples, because we're very misunderstood and underrepresented there. Uh, and I feel like, as a physician, I need to be the healthiest I can be in order to serve my people in the best ways. And it really clarified for me that maybe academia is not the place for me. And I know that that's not all Native people, and we do need Native people in academia. But for me, I feel like I can be the best physician based off of my experience when I'm surrounded by my people.
That makes sense. I actually have a follow-up question for you, Victor. Something that I've noticed from my own experience being a medical student is that how helpful it's been for me to have mentors that have similar self-identifiers, whether they're Black or women. And I think it helps me to see what I could be or could not be a resident and as a physician later on. I wonder how your experience has been in finding mentors that have been able to influence you and where your path is going.
Yeah, mentor has been everything for me. The few like at Harvard Med, there are 2 Native Americans on all the faculty, 2 Native and only one physician. Another one's in like the global health department. He's a PhD. So really, there's only one doctor in all of Harvard Medical School who is Native, and he happened to become a very close mentor of mine, and supported me a lot. And I felt like, that was part of the reason why I went to Harvard Medical School as well, was because I knew that he was there. I had a prior relationship with him as a mentor, and he happens to hold one of the highest positions in Boston. He's the chief medical officer of Mass General Brigham, and the first Native American to hold that position in a hospital system, and not only a hospital system, but one of the best in the world. And for me to see him in like the highest position in a hospital system that a doctor can be placed in as a Native person, it's empowering for me to see that. And I think it does go a long way for me. Like I still feel the effects of it. Like, he did that, and I feel like it's empowering still for me to think about that.
Yeah, he sounds like an amazing mentor.
I know we only have like 2 minutes. Can I make a quick comment on academia and non-academia? So for you guys, like, and all the medical students that are out there, be proud of what you're doing. You've already accomplished a lot as to what you have already achieved. You have nothing to prove to anyone, and do what makes you happy. And find mentors, find positive people in your life that, empower you and bring you forward. Get rid of negative people who are the naysayers. I would not be anywhere like, I wouldn't get into Hopkins. I wouldn't get into anything like if it wasn't for my mentors in medical school and in college. And my high school biology teacher, all these people, believed in me. And so pay it forward when you're at that position of power to others around you, like you're already planning on doing. But I'm proud of you all. I've learned so much. You guys are young people and you're giving me hope for the future, so thank you.
Thank you so much, Dr. Gowtham. And as you mentioned, we are in the last minute. Any other final thoughts before we let you go?
I guess I just want to had one thing I recently came to conclusion with about myself is that in majority of my med school, I was trying to fit in. And I feel like that's not as important as just realizing and knowing that you also belong. So like whatever you guys end up doing, just continue to remember that like whatever space you find yourself in medicine, you belong. And this is also just a reminder for myself that people can fit into whatever you are. You don't have to fit in.
Absolutely. I think it's so easy to think that maybe you don't fit in and compare yourself to others, but you're there for a reason, absolutely. And you deserve to be there. I'll just reaffirm you. Any final thoughts, Victor?
I'll leave it at that. That was great. Totally just reaffirming that.
Yeah, you all deserve so much for taking the time to answer all of our questions today. I learned a lot. This was all so informative from all three of you, so thank you so much.
Thank you for listening. This is great.
Thank you.
Oh, Dr. Gowtham, I can't hear you.
I just said, please feel free to give out my information if anyone wants me to like read their CVs or their personal statements for residency or whatever. You know, feel free.
Thank you so much. All right. I guess this is the end. So thank you everyone for tuning in, I guess. And we can definitely send in Dr. Gowtham's personal contact information and also Victor's. Great. Thank you. Bye.
I'm trying to put my email in, but it's not entering. It's my first name, that my last name at Yale.edu.